My next presentation, how to choose appropriate polyp removal technique, EMR or ESD or polypectomy. Yes. Not sure why. First of all, I'd like to talk about the indication for polypectomy, EMR, and ESD. The indication for the endoscopic treatment strategy could be based on tumor size and histology. And first of all, how to treat SSL-related lesions. The indication for SSL, maybe in the Western countries, we know we should resect all SSL despite of the tumor size. And this paper from Dr. Murakami, Juntendo University, they reported the distinct endoscopic characteristics of SSL and SSL with dysplasia. They reported the double elevation or some depressed component, a tumor nodule, redness, depression, and type 3, 4, 5 PIP, the feature of dysplasia. And how to treat SSL? Still, there is no consensus in Japan. But for my personal opinion, even for SSL without dysplasia, we should resect the lesion more than 1 centimeter in diameter. And of course, as Dr. Murakami's paper, when the SSL showed that nodule, redness, depression, type 3, 4, 5 PIP, there is some possibility of dysplasia of cancer. So those lesions should be resected by endoscopy or surgery, depending on their estimation depths. And apart from SSL, some patients had lots of SSL and large SSL, so-called serrated polyposis. They have high risk of carcinoma, so they should be followed annually. And as for the long-term prognosis of SSL, still little is known. But from the several papers, the overall incidence of carcinoma in SSL is relatively low compared to conventional tubular adenoma. And how to treat SSL? Is cold snare polypectomy enough for the SSL? There are several papers. This is from Dr. Ito, the resection depths and layer of cold snare polypectomy versus endoscopic mucosal resection using injection and cut using electropotry units. They reported the depth of submucosal layer could be shallow by cold snare polypectomy compared to hot snare EMR. And as you know, the muscularis mucosa is difficult to cut by cold snare polypectomy. And complete resection rate is statistically lower in the cold snare polypectomy compared to EMR. And importantly, vertical margin positive or unknown rate is much higher in the cold snare polypectomy group. So it is really important, don't perform CSP for the high-grade dysplasia or carcinoma. How about this lesion? Small one. This is the case at our National Cancer Center. Red polyp. And some, if you look carefully, some stretching fold. Could you observe? And in the NBI, there are difference. The top of this small tiny polyp, some vessel pattern, brownish, and the right side, left side different. And the lower part could be the normal process. So this could be some SMT-like elevation and some fold stretching, if you look carefully. But unfortunately, the doctor didn't perform any chromoscopy and performed a cold snare polypectomy for this lesion, and histology was well-differentiated adenocarcinoma. And using the Desmin stain, desmoplastic reaction was observed around the tumor, and Desmin staining showed no musculus mucosa, and desmoplastic reaction was diagnosed caused by cancer invasion. So no more cold snare polypectomy for cancer, and image-enhanced endoscopy with chromo is really important. So keep this lesion in mind, please. Next topic, how to choose EMR or ESD for large LST lesions. This is the paper from Endoscopy. Yamada, our colleague, the first author. And LST non-granular type, about 45% SM penetration could be multifocal. So these lesions should be resected en bloc. But even for LST granular type, 16% SM penetration could be multifocal outside the large nodule or depressed component. So not only LST non-granular, but also LST granular could be resected en bloc. And more importantly, the pit pattern show the highest diagnostic accuracy. However, the sensitivity of pit pattern for LST-NG was 71%, and sensitivity of pit pattern for LST granular type or just 52% because of the protruded morphology. Specificity pit pattern is really high, 98% for both regions. So keep in mind to understand the limitation of pit pattern and positive predictive value. Specificity of pit pattern is quite high, more than 98%. But negative predictive value, the sensitivity of pit pattern is a little bit lower, 70% for LST-NG and just 50% in LST granular. And therefore, our indication for ESD is the LST non-granular type more than 2 or 3 centimeters, LST granular type, nodular mixed type more than 3 or 4 centimeters. But rectal net could be treated by EMR-C or ESMRL. And for the adenoma, the small lesion less than 10 mm cold snare polypectomy could. How about this LST granular type in ascending column? And what kind of lesion could be treated by piecemeal EMR? So we evaluate the SM invasion rate according to the tumor size, large nodule, or depressed component. Now from this analysis, when the lesion has no large nodule, no depressed component, and tumor size less than 3 centimeters in diameter, the incidence of SM invasion was just 3%. So this kind of lesion could be treated by EMR effectively. Yes. How to perform the effective EMR? So for the same lesion, the focusing on the nodule, the JNET classification is regular vessel, regular surface, JNET 2A, suggesting low-grade intermucosal neoplasia. And after endocardinal display, pit pattern type 4, And after submucosal injection, lifting very well. And this region, no large nodule, no depressed component. The size is around 3 centimeters or less. So the incidence of SM invasion, less than 3%, almost 3%. And another important point is adequate submucosal injection is essential. And don't perform injection multiple location. The best thing is only 1 or 2 point injection. If you inject from various sides, not only the tumor, but also the surrounding mucosa will be raised up. So en bloc resection become really challenging. So just 1 or 2 injection only raise the tumor itself. And en bloc resection by outpatient clinic possible, the histology revealed tubular adenoma, curative resection was achieved, no recurrence. And for the basic technology of EMR, no biopsy, especially for this kind of flat region. In this case, we could perform en bloc EMR by day surgery, but if you take 1 or 2 biopsy before EMR, this kind of excellent EMR would be really challenging. The final topic, how to perform ESD safely. Conventional ESD technique using the bipolar
Colorectal ESD
V-knife,
using bipolar knife,
now,
the jet V-knife, and
published
IT-knife
in
nano.
Video GIE.
This video is partially funded by the National Cancer Center Research and Development Fund.
Because of the time limitation, so please refer this Video GIE in the internet. And I also prepared another ESD movie. How about this? In the ascending column, the half circumferential LST non-granular and the center depressed component. After endocarmine dye, you could see the tumor margin depressed component. So this is LSTNG, pseudo-depressed type. And also in the center, there are a little bit deeper depressed component. But magnified NBI showed the most part of this region, regular, a little bit irregular vessel, irregular surface, but JNet type 2B. But pit pattern, 3L, 3S, 3L, 3S in most part. Only the depthless component, the pit type 5 low irregular pit and small erosion could be observed. Okay, ladies and gentlemen, please answer. How about this region? Please vote.
So, Professor Yutaka, to be honest, I do the ESD for this kind of lesion yesterday.
Oh,
the
really?
same one. Yes, but I fell. It's in the middle of the lesion is the inverted, so I stopped the ESD procedure. So, to be honest, it's the same. I choose the C.
So, could you observe the cancer invasion during the ESD procedure?
Yes, yes. In the middle of the lesion, in the center of the lesion is the invasive plane. I cannot see the plane to cut it off. So I tried to cut it off, and then I feel that I am cutting into the tumor. So I stop it. So better to go for surgery.
Yeah. Okay, the more than half diagnosed SM2. Okay, please go to next slide. And for this case, we also perform end brain, end site. After double stain, crystal white staining and methylene blue, this is a really nice image of the center depressed component. Next slide, yes. endoscopic diagnosis of end brain neoplastic, non-invasive. And this is the day of ESD. Using the short type ST food, we perform retroflexion, but at this moment, maybe this was the 2 weeks after the endoscopic diagnosis. So I observed some deeper depressed component. So at this time, I really thinking to stop ESD because even this conventional image, this could be the some cause of deeply invasive cancer, as SPAC say. But finally, I continue ESD. Oh, sorry, ESD. How about the movie? Okay. Retroflex position, injection. It's important, don't perform circumferential resection in the colorectal ESD. So I'm performing the partial marginal resection and then directly move to the submucosal dissection. And after the submucosal layer expanded, I prefer to use IT nano. And I always use this short type ST food. Oh, I'm really happy Dr. Kikuchi also like this short type ST food. And probably nobody know about this. So conventional ST food was developed by Professor Yamamoto, GT University, but this short type ST food. So I asked Fujifilm company to make this one. So this is developed by me and Fujifilm. But unfortunately, no incentive for me for this short type ST food. But it's good for colorectal ESD. Unfortunately, despite of the tumor deep depressed component, the submucosal lifting was really nice. And after completing the submucosal dissection of the retroflex position, now I'm starting the marginal dissection of the anal side using the straightforward view. And after marginal dissection, using the water jet function through this same V knife. It's really important to start the submucosal dissection immediately after partial marginal dissection. And also, this short type ST food is really nice for entering into the submucosal layer effectively. And then submucosal dissection using the IT knife, nano. Of course, as SPAC mentioned, from the endoscopic finding, if during the submucosal dissection, if we encounter the deep submucosal invasion or severe fibrosis, the no space between the muscle layer and the submucosal layer, we should stop the ESD procedure. But finally, fortunately, the en bloc dissection completed without any complications. And this is the resected specimen. This area could be the deep depressed component. This is a pathologic loop of the resected specimen. This is the deepest portion of the histology. The histologic diagnosis was well differentiated adenocarcinoma, and the muscularis mucosa invasion in the depressed component, but no submucosal invasion. and no lymphovascular invasion, and budding grade 1. So curative resection was achieved in this patient. So this lesion was really nice by the effective ESD. In the past, without the technique of ESD, even if we diagnose the interim causal SM superficial for this kind of large LSTNG lesion, we had no endoscopic treatment possibility, and laparoscopic surgery was done for this kind of lesion. Another similar case. This is the recent case. Okay, this is a tumor located in the secant bottom. And tumor morphology also the LST non-granular, pseudo-depressed type. Relatively, we could observe some tumor thickness and relatively depressed component in the center. And some stretching folds. And of course, it's really important to use the non-traumatic catheter to observe the target area. And changing to NBI. This is NBI. And also this is the center depressed area, and magnification, irregular vessel pattern, irregular surface pattern. And this is a crystal white stain. This is tumor edge, and this is the center depressed component. And now there are some demarcated area after crystal white stain here. But pit pattern here, type 3L, 3S pit pattern. There, this demarcated area. And this is the most depressed component. The pit pattern 3S, 3L, and this area type 4. The endocytoscopic image. Oh, okay. Oh, so no Q&A slides, but Dr. Spaki, how do you diagnose this lesion?
I think it is non-invasive lesion.
Oh. Hmm.
Yes. So I think I will go on with the endoscopic resection, the ESD, for this kind of lesion after the detail that you gave it to me. So it's all of the detail is indicated is not non-invasive.
Yeah. But how about this, the conventional white light image?
Yeah, with the conventional image that you provided, it seems like they have the invasive part in the middle, that they have the retraction in the center.
Okay, yeah. Oh, Spaki has like an eagle eye. Yes. As for me, also, I'm a little bit curious about some causal invasion in the conventional white image. But after the detailed pit pattern, so I thought there is some possibility of internal causal or SM1. And also, endocytoscopic image is also confirms the internal causal neoplasia. So this is a recent case, so different from the previous one. We are using the cap, mask, goggle, and it's a really tough situation for us. How about in Thailand? You also do this kind of standard precaution during the endoscopic procedure?
Yes, we're doing it. During the high pandemics is on the April, so we stop the elective cases. We do only the emergency cases, and if we do it like this.
Now in this case, the lesion located in the secant bottom, so we couldn't perform better flex of the scope. So I first do the marginal resection of the and the submucosal dissection of the oral side in the straightforward view. And then in the straightforward view, after completing the marginal section of the distal end, so we are starting the partial marginal section of the anal side using the bipolar needle knife. And after resection, so we inject the glycerol solution through the same jet B knife. And when we visualize the thick vessel, it's really important to pre-coagulation. And now you could see the very nicely elevated submucosal layer. So we are dissecting the lower third portion of the submucosal layer. And this vessel is already pre-coagulated. So we could continue the section. And you could see the muscle layer here. So it's really important to dissect along with the muscle layer. Don't toward muscle layer. Now this is the similar to pocket creation method by Professor Yamamoto et al. But in the second bottom, so sometimes only using pocket creation method. So sometimes it's difficult to visualize the cutting line. So the traction method is really useful even with pocket creation. Now the submucosal layer expand. The traction is really nice for the receptive specimen. And using IT knife nano, we are performing submucosal dissection. And the ST food, short type ST food is really nice to enter SM layer. The combination use of short type ST food and SO clip traction is really for visualizing the cutting line. Even during the ESD, sometimes we ask the patient using surgical masks. And now the marginal resection of the lateral side also performing by IT knife nano. The marginal resection, left marginal resection by IT nano. The longitudinal cutting is really easy and effective by nano. And this is almost the final part of the dissection. We are already approaching to the oral side of the dissection area. And for the pocket creation method with only using needle type knife, sometimes the opening the pocket become difficult and the final portion of the dissection become difficult. But using the IT knife nano, so the opening the pocket or the final portion of dissection is easy. Of course, considering the cost, it's better to use the only one device. But for considering the safety and the speed of the dissection, sometimes the two devices could be fine. Because IT9 nano has a very strong power for the coagulation. So we rarely use the coagulosper during the current ESD. And recently we performed the super high magnification even after endoscopic resection. Endocytoscopic imaging could be possible after ESD resection. In this case, pocket creation method with SO-clip traction are really effective. And after resection, we put the resected specimen into the saline. And we could observe the pit pattern very clearly. So this imaging is almost the same as the stereomicroscopic image and easier. And again, the histology was well to moderately differentiate adenocarcinoma, intermucosal, and lymphovascular invasion was negative, bad in grade 1, and curative resection was achieved. Okay, the final topic is endoscopic resection for rectal net, neuroendocrine tumor. The indication for local resection of rectal net is mainly less than 1 centimeter and grade 1, net grade 1, and no lymphovascular invasion, and limited in the submucosal layer. And we reported several papers, the effectiveness of endoscopic submucosal resection using the ligation device. Well, this is small SMT, yellowish color, less than 1 centimeter, and after submucosal injection, and attach the ligation device and banding, and resect under this band. The other resection completed less than 3 minutes by day surgery. And this EMR technique is really nice, cheap, quick, like Yoshinoya Big Ball. Another one, also using the ESMR technique, nicely resected, 3 minutes. Sometimes the patient refer to our National Cancer Center for conventional endoscopic mucosal resection was done, and the vertical margin was positive or unknown, and further treatment. In this case, in a previous clinic, conventional EMR was done, and the vertical margin was unknown. The histology showed the rectal net. So, first of all, I think I could again perform the ESMRL or EMR using CAP method could be possible. But unfortunately, the scar was much larger than expected. So I changed the strategy for emergent ESD by day surgery. We can do the day surgery, day ESD for this kind of lesion because the lesion located in the lower rectum, there's no risk of perforation. In this case, after marginal resection and en bloc ESD could be possible. Okay, I think we have still enough time, so I will talk about the recent paper published from our colleague in the USA Cleveland Clinic. Now, at this moment, still there are debates between EMR or ESD for large colorectal LST, especially for LST granular type. And from our National Cancer Center, we published the paper, the invasive recurrences occurred after piecemeal EMR, the several cases. So we never, Japanese endoscopists never perform multi-piecemeal resection for large LST granular type. But until now, such kind of report only from Japan or Asian countries. And still the ESGE guideline recommend piecemeal EMR for LSD granular type, and ACE group in Australia, still they recommend multi-piecemeal resection even for the large LSD granular type. And they say never experience the invasive recurrence. This is recently published in Surgical Endoscopy, Dr. Neil and Dr. Amit Bhatt from Cleveland Clinic. They compare, they conducted the retrospective cohort study and the recurrence after resection polyps with high-grade dysplasia means intramucosal cancer in Japan. And in their long-term follow-up, malignant recurrence means invasive cancer recurrence or lymph node distant metastasis occur like this. They reported their study demonstrated that local recurrence with malignancy after endoscopic resection of LSTs with high-grade dysplasia is uncommon but clinically important phenomenon, which may be associated with piecemeal endoscopic resection. If piecemeal resection is to be attempted for the treatment of these polyps, close endoscopic follow-up is imperative. Alternatively, when expertise is available, en bloc resection technique such as ESD should be the goal. ESD and other en bloc resection technique can provide potentially curative resections, minimizing the risk of malignant recurrences. I reported not only from Japan, but also from Western countries is really important. We hope no more piecemeal EMR for the large LST granular type. So, ladies and gentlemen, let's summarize my second talk. Again, JNet2B suggesting high-grade cancer. Therefore, JNet2B without invasive pit pattern performed by crystal light staining is the indication for endoscopic resection. But for the JNet2B lesion, there are still some possibility of submucosal invasion. So please perform en bloc resection. And again, LST non-granular type and granular mixed nodular type should be resected by en bloc resections. It was reported the ESD showed the longer procedure time and higher complication rate. However, the recent advancement of ESD strategy and various traction methods makes ESD easier and much faster than the previous. So using this kind of the textbook, please learn more and more about JNet classification and pit pattern diagnosis, and please conduct the effective endoscopic resection. Learning from textbook, e-learning is still necessary. コップンか。Thank you very much.